Ladies and gentlemen, dear Sabine, dear Felix, thank you very much for inviting me to this talk. And I have no disclosures. So the question is, how certain are we that channelopathies do contribute to sudden cardiac death? And looking at our own patient from the arrhythmia clinic in the Charité, we have about 3,200 patients over the last 20 years. And if you can see here that about 7.8%, 7-8% are having long QT syndrome, but only 20 patients we're caring with CPVT, and Brugada syndrome is even less. Looking at those patients who needed an ICD or were a survivor of a sudden cardiac death, it's about 9 to 7% with the long QT patients, much more higher in the CPVT patients. About 35% of the patients were diagnosed as survivors of sudden cardiac death, and there were none with the Brugada group. So looking at a prospective study from New Zealand and Australia, you can see that between the age of 1 and 35, there was about, all in all, from 490 deaths, 1.5 per 100,000 sudden cardiac death. And if you look at the entities leading to this sudden cardiac death, you can see that about 40% were not explained by anatomic findings. If we're looking for potential arrhythmogenic reasons for a sudden cardiac death, we can consider congenital heart block, fast conducting WPW syndrome leading to ventricular fibrillation, and then we have the channelopathies we will focus during the next minutes. We have the long QT syndrome, we have CPVT and Brugada syndrome. I will not go too much into detail on short QT and early repolarization syndrome. The genes encoding for long QT syndrome are those with the potassium. As you know, we have the long QT1, long QT2, and we have the sodium channel with the long QT syndrome, which is also affected with the Brugada syndrome. And we have a calcium overload of the cells when we have those mutations in the ryanodine or calcicrestin receptor, which is the reason for the diagnosis of CPVT. The typical ECG in long QT, as you all can see here, is a prolongation of the QT time. The prevalence is pretty high of the long QT, as estimated at 1 in 2,000, and the typical arrhythmia is torsade de pointe, leading to ventricular fibrillation in these patients. And these patients are young. You can see that the typical age at diagnosis is before the age of 12, and 10% risk of sudden death is what the problem is here. Genetic mutations can be found in 80%. And if we are looking at the 2015 ESC guidelines for the management of this, for the diagnosis of long QT syndrome, we have on the one hand the clinical signs, but then we also have class 1 diagnosis indication if we have a confirmed pathogenic mutation in the long QT genes. And over the past 25 years, more than 17 genes have been found to be likely pathogenic and considered to contribute to the long QT syndrome. But using evidence-based reappraisal of these genes just recently showed that 9 of these genes were actually only of limited or disputed relevance for the diagnosis of the long QT syndrome. So this led to the recommendation that in cases of questioning the diagnosis in long QT syndrome, only the genes for long QT 1, 2, and 3 should be looked for in the first instance. What about CPVT? The typical ECG we have here is under stress testing or epinephrine infusion, bidirectional ventricular tachycardia. And the prevalence is about 1 to 10,000. There is also a high risk of sudden cardiac death, and a typical age of diagnosis is also in the pediatric age group. We have genetic mutations also found in about 60% of these patients. And again, here using the ESC guidelines, you can see that the diagnosis is made by clinical judgment, but as well, class 1 again, it's diagnosed in patients who are carriers of the pathogenic mutation. So again, the question, what is the pathogenic mutation? In a recent study here from Texas, there were whole exome sequencing tests performed due to other reasons in about more than 6,000 patients. And then they looked at those variants in the ryanodine or calcicristin receptor that were reported as potentially pathogenic. And they found that about 8.8% of all these tests here considered mutations in these genes. And they compared it to a group of control of more than 60,000 patients. And also here you found about 6.1% with mutations. Case controlled study, or the CPVT study of the same hospital, was about 150 patients, and they had mutations in up to 60%. So there's a huge background of variations in these receptors, and actually they looked after clinical signs for CPVTs in these whole exome sequencing patients, but couldn't find any. So they were all actually not pathogenic. Brugada syndrome is typical diagnosis is below the pediatric age group. You know that the diagnosis is confirmed by the ST elevation in the right precordial leads, and the risk of sudden cardiac death is also high. If you look at the guidelines, here it's only the clinical diagnosis of Brugada syndrome and not the mutation diagnosis. But if you look at the more of 500 mutations that were found in the SCN5A gene, right now there is a little bit suspicion that not all these are also really pathogenic clinically. And also a lot of more than mutations only in the sodium channel here were found in Brugada syndromes, but until now there's no cellular or clinical really evidence that they do contribute to the clinical diagnosis of Brugada syndrome. So what happened in CPVT and long QT, if we have adrenergic input, it's going to give early and delayed after depolarizations, and this will lead to the typical arrhythmia and a sudden cardiac death. So how certain are we? We can look at different items. If we are looking for evidence of arrhythmogenic causes, we can look in postmortem analysis, we can look at survivors of sudden cardiac death, and we can look in follow-up studies in these different syndromes. If we look at postmortem analysis first, you all know that SIDS is worst diagnosis in the pediatric world. And in a study from 1989, Peter Schwartz and colleagues performed ECGs on the third or fourth day of more than 34,000 infants, and prospectively looked at these kids, and actually more than 30 children died during follow-up, and 24 died of SIDS. And 12 of these kids that died of SIDS had a short QT, but also 12 children who died on SIDS had a QTc longer than 440. In a study of 201 patients died on SIDS, there were mutations looked after in 7 genes for long QT. And that was also done in 181 controls. And you can see here that overall 26 SIDS cases revealed mutations in specific genes for long QT, and 19 of them were considered as pathogenic, leading to a 9.5% incidence of positive mutations of long QT genes, pathogenic genes, in patients that died on SIDS. In 49 kids died at a mean age at 14 years, postmortem analysis was performed, and actually in 35% of these children who died suddenly, 1/3 of them died during exercise, 1/3 of them died during rest. There were mutations found in 14% in the ryanodine receptor and in the long QT1 to 3 genes, also in another high percentage, giving overall percentage of 35%. having mutations, and most of the ryanodine receptor kids were male, and most of the long QT children were females. Looking at survivors for sudden cardiac arrest or ventricular fibrillation, there was a multi-center retrospect study with more than 450 patients with the diagnosis either long QT, CPVT, hypertrophic cardiomyopathy, or anomalous coronary artery, left coronary artery from the right sinus. And there was a median age of 10 years in these kids. And sudden cardiac arrest was in 7% the initial finding of these diagnoses. And there were more than 230 patients with long QT and 31 patients with CPVT. And if you look at those with long QT, sudden cardiac arrest was the first symptom in about 5%, and 20% had syncope as the first presentation of their disease. And for the CPVT, resembling our own results, actually sudden cardiac arrest was about in 45% of the patient, the first symptom, and syncope was found in 35%. Now we're going to the follow-up studies in the different entities for the long QT syndrome. You all know that over the years from the long QT registry, the long QT 2 and 3 are doing worse than long QT 1 patients. And if you further look in detail at those patients who have the long QT 1, you see that the long QT time over 500 in male sex are risk factors for the long QT 2. You have the same long QT, but non-gender effect. And for the long QT 3, you have also the male sex, and the long QT is a risk factor of cardiac events. In the long QT registry also, there were more than 3,000 patients with a QTc longer than 450. And actually 20 patients died in the first year of life, let's say SIDS. 34 patients had a syncope in the first year of life, and 16 had aborted cardiac arrest in the first year of life. And you can see that those patients who have these early events do worse during follow-up. And interestingly, beta blocker medication did not prevent other cardiac arrest during the next year if you had an cardiac arrest in the first year of life. From 2002, there was a prospective study in patients with long QT syndrome and defibrillators. And you can see here the indications from these more than 200 patients who received defibrillators. Most with long QT 1 and 2 had a syncope or aborted cardiac arrest, but also there were quite a high number of asymptomatic patients, especially in the long QT 3 gene. And these patients received defibrillators, and over time, you see 7 years follow-up, 70% received adequate shocks. And if you look at the risks, and if you compare, if you're looking for risk factors, which patients are those who receive adequate shocks, you can see that these are the patients who have long QTs, who have prior arrhythmic events, who have events on beta blocker therapy, or patients who are very young at the first age when the defibrillator was implanted. So high risk for syncope or sudden cardiac death and long QT is a long QT duration, young age, and gender, depending on the mutation, symptoms, anyway, and different genetic entities, and freedom of medication or non-compliance for physical restrictions. Coming to the CPVT, we can see that in more than 100 patients diagnosed with CPVT, over the time, they have symptoms in about 70% up to the age of 20. And they also have 50% chance of receiving cardiac life-threatening events 20 years up from their initial diagnosis. And what are the risk factors for those arrhythmic events? These are young age, a diagnosis, aborted cardiac arrests, and the absence of beta blockers. And the multi-center retrospect study of more than 200 patients, all from the pediatric age group, you can see also that the circumstances leading to symptoms, either syncope or cardiac arrest, were exertional, emotional, or normal activity. And actually 80% of these patients in just 3.6 years were symptomatic with either syncope or cardiac arrest. And although most of them were on beta blockers over time, 25% of these patients were symptomatic on beta blockers. And a lot of patients had shocks. And as you can see here in another study of 24 patients receiving defibrillators, 14 of them receiving shocks, all with CPVT. There are a lot of appropriate shocks and inappropriate shocks as well. And you have a lot of patients who also have electrical storm and recessant ventricular tachycardias with this disease. So the high-risk patients in CPVT are those with young age diagnosis, history of near sudden death, and absence of beta blockers. Coming to the last group, the Brugada syndrome group, prospectively studied over the last more than 20 years. Also here from the Brugada group, more than about 100 patients with Brugada syndromes. A quarter of them had defibrillators implanted. And what the authors tried is to create a risk model for the risk of cardiac events. And you see that those patients do have a high risk for shocks or for aborted cardiac death if they have symptoms, if they have a spontaneous ST elevation ECG, type 1 Brugada, or if they have sinus node disease or other conduction anomalies. So those patients are at high risk who present with near sudden cardiac death, who have syncope, who have fever-induced or spontaneous type 1 ECG, or have other atrial or ventricular or AV node abnormalities. So let me conclude that 40% of the patients of sudden cardiac death are not explained by anatomic findings, which makes it reasonable to think about arrhythmogenic reasons. That channelopathies do substantially contribute to the near sudden cardiac death, and the incidence of primary electrical diseases or channelopathies is about 10% in SIDS and maybe up to 35% in the sudden unexpected death syndromes of kids. In our own patient population, channelopathies contribute to 9% of all arrhythmia patients, and about 10% actually had an ICD or presented with sudden cardiac death. For each entity, there have been specific risk factors being established, and the genetic analysis has to be interpreted with caution due to the high amount of variation due to variants of unknown significance. Thank you very much.
Thank you very much for this excellent talk, Achim, containing these very important information about the risk stratifications in these patients with arrhythmias. I don't see any questions from the audience, and this is the reason why I want to highlight that the audience should give some questions in this question and answers field, that we can make it more interactive. But to enhance it a bit with the discussion, I want to address two aspects of it. It is very interesting that if you look at the data from the New Zealand study, that you have a peak at very young age, and then it drops down to nearly zero, and then it rises continuously to the older age. Is there any reason for that? And the second aspect of my question would be, knowing that the CPVT has a very high number of first presentation with sudden cardiac death, is the time come that we need to introduce ECG testing in school age? These aspects, probably you have the answers for these.
Maybe the first question is a little bit easier to answer. The study group of the New Zealand and Australia patient was from 1 to the age of 35. And if you look at the data, they were the most common reason for not unexplained death was coronary artery disease, actually. So I guess this contributes to the age difference here. And coming to the other question with the CPVT, I mean, we have this discussion with the long QT also, and it always goes into who's doing screening tests in the normal population or in athletes. And this is a study which is one Congress Day wouldn't be enough to have it for. But I think the bottom line is that what we actually do with our patients, if we see more than single ventricular ectopy, more than just PVCs in routine Holter ECGs, we are thinking about family history, and sometimes we even perform stress testing in the small kids using epinephrine if we have more than single PVCs on the Holter ECGs. So yes, maybe.
Okay, so the time is not yet to come for a standard and routine testing in school age.
Just in Italy, maybe.
Yeah, just in Italy, you're right.